Welcome to the Health and Life Sciences Quality Panel. What we're going to do is give you a brief description, brief bio of each of our guests. And as you can see, we have an all-star lineup today. And we have 3 questions that we have posed and asked them to focus on, at least to choose one of the questions, and give us a brief presentation on that question. And then we'll open up to the audience for questions that you will pose. So let me start to my immediate right with Karla Schnell, who is the National Healthcare Practice Clinical Lead at Centric Consulting. She's responsible there for developing the organization's strategies and service offerings while leading delivering all healthcare projects nationwide. She's spent more than 25 years deeply engaged in healthcare industry and clinical practice as a health systems executive, IT and clinical informatics professional, and consultant. Staying close to her training as a nurse, Karla works to drive change management initiatives and implement healthcare information technology to achieve true organizational transformation. To Karla's right is Evan Grossman, who is Athenahealth's Vice President of Client Performance. He's responsible for provider and practice optimization. Prior to this role, he was a Vice President for Consulting, responsible for Athena's consulting organization, and Vice President of Product Strategy, responsible for Athena Clinical's electronic health record service. He joined Athenahealth in 2010. Prior to that, Evan served in senior management positions in several technology-based companies, and has also been a consultant to McKinsey & Company and a journalist with PC Week. Junaid, Dr. Junaid Sheikh is Director of Quality Improvement at Mount Auburn, Cambridge Independent Practice Association. Junaid has vast experience working in the healthcare industry, both in the U.S. and in Pakistan, in multiple roles, ranging from the practice of medicine to managing multidisciplinary teams. He received his medical degree in Pakistan and more recently received his MBA here at Boston University. Junaid is interested in the strategy and operational aspects of successful healthcare systems and how these systems use big data to improve quality, efficiency, and profitability. And finally, Dr. Mike Rosenblatt. Mike holds multiple roles: senior staff surgeon, surgical intensivist, director of the trauma service at Lahey Hospital Medical Center in Burlington, the tertiary facility of the Lahey Health System. And he's also the chief medical officer, which he's been since 2011. He has an MD from Jefferson Medical College, and he has a master's in public health and an MBA from Boston University. He's a clinical associate professor of surgery at Tufts Medical. And in addition, and this is quite relevant, he served 10 years as an examiner with the Baldrige National Quality Program of the U.S. Department of Commerce, including a 3-year appointment as one of the 12 members of the judges panel for the Baldrige Award. As I said, an all-star panel. The 3 questions that we've asked them to focus on, or at least in part to focus on, are these. Number 1, what are some recent trends that you are seeing in the healthcare delivery system in terms of quality and quality improvement? And how do you think this will impact the future of healthcare delivery? Secondly, give some examples from your company or other places where you have observed quality improvement initiatives that are particularly relevant and that are particularly interesting to observe and have potential of applicability. And thirdly, if we were to switch, and we're in the transition process towards value-based health systems, if we were to switch towards that payment system more fully and eliminate fee-for-service, do you believe that quality of care will improve, and why or why not? So let's start with Karla.
Thank you. Appreciate being here today. The first question that I really want to address is the recent trends that I'm seeing in healthcare delivery systems and how I think that impacts quality. I left the clinical setting and moved into technology longer ago than I lived. Anyway, we've been trying to put technology into the clinical setting for a very long time, I think we've done a great deal, but there's much more work left to be done. The good news is, I think today I'm seeing, as I work across the country with health systems, hospitals, physician practices, I'm seeing a real push to try to use the technology that's there. It's not always easy, but I think that everyone has really come to grips with the fact that the technology has to be part of the solution, and it really is the only way that we can enable ourselves to achieve the level of quality we want to, because there's simply too much information if you don't utilize technology to really guide you on what to focus on. And we heard some of those things earlier today in the keynote. So I think, for me, I'm happy that we're finally getting to that point, and I think it's important that we go beyond just the electronic health record. We need to use the technology to enable many of our processes, data collection, so that we can really start to research. So I think that's valuable. I think the other trend that I see, which I'm personally quite happy about, is the use of the entire care team in providing care for patients. So I respect physicians, have worked with physicians for a very long time, and that's wonderful. But there are many different providers that we really need to engage in the health system today. And I think as we kind of distribute the care of the patient and we collect the insights and the effectiveness from all of these different types of providers, I think that we're getting a much clearer picture about what's happening with the patient and a much better understanding of what we need to do to change up the quality. So I think that's valuable, and I think it happens to be pretty timely given the cost of healthcare and the fact that we all know it's not sustainable. So we really need to do that, and I think people are starting to see where there's real value. So switching gears, the third question is the other one that I really wanted to talk about, and that's the move to value-based care. And I have spent a lot of time talking with practitioners about that, really in a number of countries. But I think, the move to value-based care we've talked about it for a long time. And again, it's not an easy thing to do, but I have talked to physicians who really kind of moved away from the volume and into the looking at more value, and I find that they're much more satisfied with the care they're actually able to provide. They're able to focus their intellect and their intelligence on what's happening with patients, and the patients that have the most complex problems, that have the worst outcomes, so they can really, focus their time there and spend less time on the patients that, need to come in for annual kinds of care, may be able to be handled by nurse practitioners or physician's assistants. So I think we're utilizing kind of the capabilities that we have in the best possible way. And I think that as they're really required to produce quality outcomes, I think that they pay a lot more attention to cause and effect, so what they do and what that means in terms of better outcomes for patients. So I do think it's going to increase the quality of life and the quality of care that we provide, and it should help to drive down costs, albeit not all overnight. So I'm kind of all in on that. I think it's great. So with that, I will hand off.
Great. And I'm going to try, I tend to go all over the map on this because it's such a broad topic. Let's start with the last one, that sort of fee-for-service to fee-for-value. I think we have to be careful because initially we will see big gains in quality in terms of how we measure it, just because right now very few people are tracking the things they need to track. So, for example, most patients look healthier than they are because of the ways we track how risky a patient is. And one of the first things that happens, probably you guys can, is all of a sudden when hospitals or doctors get their scores, like, but wait, my patients are much sicker than this. And it's like, well, you're not documenting it every year on a claim or following. And so there's this process where quality improves, but what actually improves is the tracking of the care they were already delivering. And I think most of the improvements over the past few years, and probably the next few years, that people take credit for will be in that range, right? There's a lot of times, for example, when you look at the very low adherence to mammograms or colonoscopies or other measures, process measures of quality, the people actually have them, it's just the doctor didn't know, right? Because it was done with another doctor, it's a piece of paper, it's a 10-year recommendation, it's buried 9 years ago in the chart for whatever it's. So I think when we talk about improving quality, there is this period where we just get up to the basic level and then start having a benchmark we can improve on. And I see us in the US right now there. The other thing is, I'm always amazed by Americans' ability to complexify things. Because when
words.
Right, yes. Even words. I can verb any noun. So there's some really simple, so, when I talk to some of our primary care doctors, like, so how, who are successful, like, so how have you reduced costs? And I go, it's really easy. Stay open till 10 p.m. and review every MRI. And, half of the per capita cost in this practice was not all the difficult chronic patients that were falling off meds. It was just people going to the ER because the practice wasn't open, often with sick kids, right? And so you stay open until 10 p.m., right? And doctors just ordering MRIs because the patient felt better, they felt better when they really weren't indicated, right? Likewise, there's this huge effort to reduce 30-day readmissions, right? Everybody's, right? And there's actually two things you need to do to reduce 30-day readmissions. One's about $8, one's 30 cents, right? It's a taxi voucher and a Ziploc bag. And when you discharge a patient, right, you also have to make an appointment with their primary care doctor within the next 3 days, and you give them the Ziploc bag and tell them when they get home to their medicine cabinet and put all their meds in it. You give them the cab voucher to get to the doctor because they may not be able to get to the doctor without a taxi picking up. And that will reduce 30-day readmissions dramatically. Right? Because maybe you need to send someone to their house to clean out their med cabinet because maybe they'll be volunteering there. But it's not necessarily these really complex, new immunosuppression therapies, which are all wonderful. But it's some very basic stuff. And I think what's exciting me is when you look at the variation in cost and the variation in quality, there's no correlation, right, in U.S. healthcare. So the good news is we can probably both improve quality and reduce costs just by figuring out what are those things that work, right? Because the problem, I think we have a bigger cost problem than a quality problem in healthcare. Conveniently, the two are very interrelated, and if you can improve quality, you can also reduce costs. Most, I think, in any industry. So that's the exciting part for me. In terms of the interesting things being done, so at Athena we've got a database of about 70 million patients, which is probably the largest in the country. It's about 3 colleges worth of data where we can look at who's doing well, who's doing poorly on different areas. And we've been spending a lot of time trying to understand with diabetic populations what has a controlled hemoglobin A1C. And what's the most interesting thing to me is when you look at the correlations of the doctors who seem to have the best control of their patients, it correlates with a lot of other things you might not expect, like they're more profitable, they spend less time with each patient, and as sort of our director of research has said, competence is a core competency in being a physician sometimes, and so those who are good at those other things tend to then be good at quality. So again, I'm optimistic that as we move toward there's a lot of hope. Where I'm pessimistic or concerned is the problem is that incentives tend to work, and if we look at a lot of the programs that are being put out there, they get very specific in terms of especially process measures. So people know process versus outcome measures in healthcare quality. So because outcome measures are very hard to do, most of what the focus has been on is these process measures. So are people getting their mammogram? Are they getting the colonoscopy? Other things which hopefully will correlate with better outcomes. But there's so much push to get those processes controlled and measured. I'm worried we could stifle some innovations and focus on driving real outcome benefits. So.
Thank you. So actually talking a bit more about data, because I'm a big data person. my background, I focus on healthcare analytics, when I did managing and everything. The biggest trend I see is this real push for everything driven by data. You know, there's data coming from payers, there's data coming from hospitals, there's data coming from us as an IPA to the practice, from everywhere and anywhere. But there's a problem with that too. There's too much data. So one of the biggest things I've seen is these practices and practitioners are being overwhelmed with lists coming from everywhere and anywhere, just lying on their desk, not knowing where to start, not knowing what to do with them, not knowing which is a priority over the other. And a lot of it's also redundant, since the data coming from some of the payers are also coming from us as an IPA or from the hospital. It's not necessarily coordinated to give a more concise report, a more focused approach to them. So I think the biggest thing that worries me about the practices and healthcare is that there's too much data analytics going on. And what we need to do overall is to make it more focused. You know, every practice, every organization has some unique qualities, whether it's their strengths and where their weaknesses. And we got to stop just data dumping on practices and physicians. And as an IPA, what we've tried to do is, since we do our own reporting, we've tried to control the reports that go from the payers to the IPA as being the filtration system, have the payers send us the data reports, the quality reports. We also try to put the reports together from all the payers. We deal with Tufts, program, Cross Blue Shield, Tufts TMP, Tufts PPO, Tufts HMO, and a lot more diverse insurances. So what we do is we take all these reports and we try to give them a more comprehensive report, something that's more easy for them to handle and manage and more focused. You know, that's the biggest thing that worries is the physicians are overwhelmed. Even some of the office managers, practice managers who are MBAs, BBAs, whatever, who have been in the industry for a while, they just don't know what to do with all this data. So that worries me, but I think there is an approach of being more focused, almost like focused consulting with the practices, saying these are your weaknesses, work on these are your strengths, keep focusing on them and re-emphasizing what you've been doing with them. So that's the biggest thing I see with too much data. The other thing I see is that there's a shift in these practices as we move to value-based care to a patient-centered medical home. PCMH, certified by NCQA, or now these other organizations are coming involved with this, is a great push for the industry to move towards. A new model of care that's more integrated, more care group-oriented, not just the physician, moving away from a physician-centered practice to more of a patient-centered practice. And there's a lot of work. In our own organization, John D'Angelo sitting here, he's a NCQA ACO facilitator, PCMH facilitator, and he works with these practices on a daily basis to develop new processes and systems. They're trying to improve the quality of care, get recognized for that. But one of the problems with that is that it involves a lot of work, a lot of financial and time commitment from the practices, not just for the transition and transformation into a PCMH, but just keeping that up. So a lot of the practices and physicians are at a point now, those that have done it for 3, 4, 5 years, are worried, is this still financially sustainable for them?
Is there any ROI?
No.
Okay. So no one's making money, is what you see, right? Just because they're doing all this because they're delivering better care, not because they're getting paid.
Exactly. There's this belief that in the future, the state, the government, someone will give them an extra incentive to kind of keep doing this as a PCMH. But right now, they're really worried. There's a lot of commitment, a lot of additional staffing, a lot of work with transitions of care, like 30-day readmissions and everything that these practices are involved with. But is it financially sustainable right now? No one knows. Analysis have been done by certain practices saying that they barely break even or they're at a loss. And they're hoping the money from quality will increase over time and help support that, but they don't know.
Are you building CCNs yet?
But again, CCMs, if you're in a value-based care model like we are, it comes back out of your budget. So your surplus at the end goes down too. So it's not a simple way to just bill for CCM, because that's a lot of the practices talked about, but it comes back out of your initial budget anyway, so you have less surplus over time. But we are, as an IPA, trying to move towards a care model where we are incentivizing them, where as their quality bonus program we have the organization, we give them We plan on giving them a more financial incentive to become a PCMH to help them cover the cost of the staffing and work involved with it. But it's not that simple. It's not an easy decision. If you look at the care model, value-based care, yes, you get more care out of it. You got to also have the financials available to do it. And a lot of the practices we work with are independent, so they're not owned by hospitals, and they don't have that backing or that financial backing from hospitals to kind of cover the cost additionally. It's these individual 1 doc, 2 doc, 3 doc practices that are barely surviving as it is, and now they're doing this on top of that. So that's something that worries me, that even though it's a great care model, it probably might not last unless there's some incentives or changes in the governing bodies pushing for these practices. The other thing I've seen, so a couple of years ago at an IPA at the quality department, before I became director, our initial push was, you go to practices, you got to improve on quality metrics, you got to improve your colorectal cancer screening, you got to improve your breast cancer screening. We go to them, we talk with them for hours, and just tell them where they need to, what measures they need to work on. But we didn't see the return on all that effort we put into it. What we came to recognize was that the issue wasn't that they didn't know what to work on. They just didn't know how to do it. They didn't understand what quality improvement was. They understood what quality was or what quality of care is, but they didn't know what quality improvement was. How do you do that? What do you do? What's the process? What are the steps involved with going from where you are to where you want to go? What's the timeline involved with that? So as an IPA, we really pushed this year as a component of their quality bonus as PCP, specifically as specialists also, that there is a portion where they have to learn PDSA, Plan, Use, Study, Act. And we taught them the IHA model of quality improvement, the science behind quality improvement. And we really pushed this year, instead of telling them what to work on, what they need to work on, we told them how they can do it, how they develop a process, a system to improve. What do they look into? What do they need to do as a data perspective? What do they need to do, the steps involved with it? The biggest worry is with a lot of physicians, well, we don't have time to work on 8-month projects or 1-year projects. But wait, hold on, this is not a scientific project or scientific research study where you're looking to print something or publish something. This is a short, rapid PDSA. You work on something for 2 weeks. See how it goes. You plan it out, you do it, see the feedback you get when you study it, and then you act, you adapt, adopt, or change accordingly. And you work on it continuously. That's the whole idea of CQI, which is the new, the new trendy word instead of just QI and CQI. It's continuous. You're not doing this for 6 months and then after 6 months doing this massive research project or research study on the data you've got. No, you do it for a few weeks, do it for a month, then adapt to it, then do it again, then change, and see the growth and changes over time. So once we pushed that with the practices and told them how to work on PDSA, we've seen a massive improvement in quality metrics, and more than that, their approach, which has been very supportive and very fulfilling for us as a quality department, where we don't have to go harp on them. They already come to us saying, so we're focusing on this is our process, we need you to help with the data aspect. Well, great, that's something we can easily do with you. So now, instead of just telling them what to do, they're working on it, they know how to do it, and we're just helping them out along the process. I'll pass it over.
I've had to change what I was going to say 3 times now. One of the advantages of being out there is to learn from people that are here. So I hope you're going to learn too. So what I heard, and from my viewpoint, so I'm a practicing surgeon that spends 25% of my time doing clinical activities. The reason I do that is because I can feel the pain. And if you can't feel the pain of what it takes to actually provide care, then from my perspective as an administrator or a manager, I'm relying on other people. And so that's why I continue to practice. I would say that over the last 15 or 20 years, there are 2 major changes in terms of quality that are different. Are this concept that there actually is a continuum of care that we have to worry about. So this issue of 30-day readmissions as a CMO of a hospital, that's the metric that I'm measured against. But in reality, in a system, in a continuum of care, ideally you don't want anybody admitted, period. If they're not admitted, they can't be readmitted. And then if you manage the follow-up with their primary care physician appropriately, I love the analogy that you said, it's the taxi in the plastic bag. You got to get them in to see their primary care doctor to reduce the likelihood that they're going to be readmitted. That's not a hospital-based problem, but it forces you, depending on what your system looks like, to work very, very tightly with your primary care physicians. So the organization actually in Massachusetts that has not been penalized in the last 4 years for 30-day readmissions is Bay State. One of the reasons is that they have this very tight relationship with their primary care physicians, and that's what everybody needs to start to be moving towards if they want to control their readmission rate. I think the other trend clearly is the alignment of financial incentives towards quality. That did not exist 15 or 20 years ago when I got into the quality arena. It was soft money. It was invisible money. It was, well, we really should do this because it's the right thing to do. The Lahey Hospital Medical Center lost $2.5 million, left $2.5 million on the table last year. It's no secret that we lost $27 million last year. So when you leave $2.5 million on the table, that's a huge chunk of money. So what can we do? How can we invest? What's the return on investment for little things to reduce that, leaving that money on the table? So I think that's a huge breakthrough in terms of pushing us in the right direction in terms of quality is now we can see what it's costing us, and then we can calculate a return on investment, and we should be investing to do the right thing, because not only is it right to do the right thing, but we won't lose as much money, or we might actually make money in this deal. In terms of what's particularly relevant in quality improvement for your company, for my company, for the last 15 years, I've been trying to institute the Baldrige framework for quality improvement in our organization. And until this year, it's fallen on deaf ears. So the Baldrige framework is a performance management system that allows you to understand the relationships between leadership, strategy, and what the customer or patient wants, and figure out what your strategy should be to support what the patient needs and wants, and lead to provide that. And then working with your human capital and your processes, basically making it happen. And it's an iterative process that you basically evaluate how you're doing and figure out where your strengths are, support those strengths, identify your opportunities for improvement, and fix those opportunities for improvement. So at a different level in terms of quality, what I'm looking at is what is the quality of the entire organization in delivering whatever it is we're delivering. In our case, we want to deliver because we have an integrated group practice. We have our primary care physicians linked with our hospital. We're trying to provide quality care that should, if we do it right and have the right metrics in terms of performance, deliver on all these other quality metrics. And the problem with the quality metrics are we tend to measure things that are easy to measure. And because you can figure it out from a billing document, you can figure it out from some download to CMS, but in reality we're missing so many things, and those things are essentially communications. The drops in communication that occur within the hospital between providers that add to so much waste, between the providers in the hospital and the primary care physicians, the collaboration between the hospital or primary care physician and the insurer. Those communications fail. So I've been presenting this at Joe's class for the last 6 or 7, well, probably 10 years now.
At least more.
Yeah, and we just kicked off our first self-assessment this week. So it's a long journey, but I think if you look at organizations that have taken a journey like the Baldrige journey and look at their results on all the metrics that we're talking about, they tend to be the highest performers. And that is not an accident. That is because they've designed their system to provide the results that they do.
Can I add one more thing?
Of course.
On question 3, which is on, is this move to fee for value going to help? I mean, I can't see how it wouldn't, because the biggest problem, I think, you think of the traditional sick care model, right? We don't really have health care, right? You go to the doctor when you're sick. Is that from a quality perspective, all these lists you're getting, the most important patient is rarely in front of the doctor, right? The patients you actually, the diabetic who's, just deciding to go out for ice cream or whatever, all of the important, it's the important versus the urgent, right? All the important patients aren't there, and there's very little in the fee-for-service reimbursement model that gets you to focus on those important patients. And so the hope, right, is that by focusing on the value, you will then get people to focus on those important patients, as opposed to, and it's not just hypochondriacs who show up at the practice, there are really sick people there too, but as opposed to the people that may be showing up after it's too late, right, in the ER setting.
And can I just add one quality metrics in general? So we talked a lot about 30-day readmissions and how the practices and the hospitals are really forced to work on this. And we worked a lot with Mount Auburn Hospital. But what you look into the data, what you see is they're told not to bring in, to reduce unavoidable admissions and inpatient admissions. At the same time, they're told to reduce readmissions. So when you reduce avoidable admissions, you only bring in the sickest patients. So when you bring in the sickest patients, you also have a higher rate of those readmitting because your N is smaller, and you have a sicker population. So by nature, your readmission rate actually might go up because you're only dealing with the sickest population instead of the healthy ones that wouldn't have readmitted. So you're hurting yourself in one aspect by doing doing the other thing. So it's a lot more complicated and hard when you really get into the data and the numbers of everything.
Interesting point.
I still haven't seen hospitals, please disagree, that have figured out how to reduce admission. I mean, there's just no financial incentive to reduce admissions right now.
Well,
except for the very small percentage of capitated lives.
Well, it's not so small anymore. We're pushing 40%.
Wow.
As of our most current contract cycle. So this is the conundrum in terms of this switch. When do you go from a fee-for-service to value-based? Because you have to change the way you approach a patient. Just as you said, you want it for a fee-for-service model, yeah, let's go fix your hip. For a value-based purchase, let's give you some physical therapy. It's cheaper, and it probably is just as effective. And you can't ethically, I don't think, treat people, let's see, you're fee-for-service, we're going to treat you this way, and you're value-based. You can't. There are people that probably do that, but as an institution, we're certainly not advocating that. So at some point, you have to take this leap and say, we're now going to be focusing purely on value-based. Now, the reimbursement model for a physician may very well drive that. And at our own institution, we were paid for years and years and years in a black box salary model, completely separate from your activities. So when I sat down with a patient in my office, I wasn't going to get paid any more or any less, dependent on whether I offered them an operation. And we were the last group practice that had that model up until 2 years ago. Now we have a component of this that's incentive-based. About a third of it is volume, and about 2/3 of it is quality. So one of those switches that will happen when we go to value-based is that volume will go away, be replaced by another third of quality.
Why don't we open it up to the audience? I can see that there are several of you who do want to ask questions. So let's start here, please.
Michael, just running back about what you were just saying now, what is, how are you measuring quality? when you have that value-based model of the physicians, how are you measuring the quality of their work?
So we have a problem in that a lot of our payers tell us what quality is because they pay us based on those quality metrics. So you have HCAHPS, patient satisfaction, that's rolled right into what our quality metrics are. Readmission rates. Almost all of our primary care providers are linked into some type of ACO, and the ACO metrics are driven by what the insurer says this is what quality is. So that's in large part how we define what quality is. It's patient satisfaction and the metrics that the external payers tell us are quality. We have a small component of that is our own quality metrics that will probably vary. They do vary from department to department to department. Right along your line of what's our pain point right now, what can we focus on specifically for this department, be it colonoscopy screening, which is a bigger problem in this department than it is in this department. And there may be, for instance, our hospital medicine group is focused very much right now on length of stay, and which is it's a bit of a challenge because you're getting the sicker patients getting admitted now, and length of stay by definition, because they're sicker, it's probably going to go higher. Our case mix index goes up every year, and our length of stay goes up every year, but our logistical requirement is that length of stay go down, because we're in an enviable position because we don't have that many beds, and we run 105% occupancy. So in that situation, we need to drive our length of stay down, and we're already in the Council of Teaching Hospitals database. We're the third strongest performer in terms of case mix index versus length of stay. So they're still incentivized to reduce the length of stay. The problem is, most of the time, the length of stay is not their problem. It's these breakdowns in communication between different services. So that's where you have to kind of work the incentives. Radiology has to do a better job. Cardiology has to do a better job in service delivery.
I'm just going to add a little bit on that. When we talk about quality metrics and what they are, what's interesting is each payer sometimes has different quality metrics and benchmarks for the same measure.
Different definitions of diabetes.
Exactly. Different definitions, even the different blood pressure goals for a diabetic or a hypertensive patient. So that complicates it because then the patient and the physician is saying, all right, so what's the payer and then what's the benchmark? That's not easy to do. And then you add the complexity where quality metrics from the payer take time to catch up to what the clinical guidelines are for the physician. Nowadays, the biggest thing is the questioning the value of a mammogram. The quality metrics are still there. They're a couple of years old, and they're probably not going to change for a couple of years. But the treatment and the process and screening for mammography, or how frequently do you do blood pressure checkups, or HbA1cs, they're changing clinical guidelines. Now the physician is in a conundrum because do I follow the clinical guidelines, or do I follow the quality metrics that drive my financial incentives?
So just on metrics, if you want, the 33, we look at a lot of what we call the ACO 33, which is what you need for Medicare shared savings and the Pioneer ACOs. And one of them is CG-CAPS, which is patient satisfaction. There's about 5 outcome measures in terms of hemoglobin, A1C, blood pressure, and then they're mostly processed, well visits, immunization. The challenge I have, and hopefully we're lucky in Massachusetts because Blue Cross is really driving a lot of measures. Most of the quality nationally is driven by Medicare, and while that's good in some ways, there's 2 populations that Medicare doesn't care about, and that's obstetrics and pediatrics. And so there's really very poor research and guidelines on quality for what most people would actually care about for health. Not most people, what is in 2 very important populations from a healthcare perspective.
And in Blue Cross, they really follow HEDIS and NCQA as some guidelines for quality measures.
Betsy?
So if you think of yourself in a time machine and you go back 20 years, so you're in the 90s, and if you think of quality metrics, payment, methodology, and consumerism, back then very little consumerism in healthcare. the payment, even though it was fee for service, there was trying to be capitation, at least in Massachusetts. It didn't work out very well. A lot of severity adjusting was really kind of nascent at that point, didn't work. And it was really more adverse events for quality metrics, right? So now you're into looking at quality metrics that are very heavy process-oriented, a few outcomes. You're into global risk again, but the consumerism is increasing rapidly. Picture yourself in 20 years from now. What do you think for those three things? What do you foresee for consumerism, the payment mechanism, and quality metrics?
Okay, so, and I may need to come back to this, but from a consumerism standpoint, I think that's going to continue to explode. I mean, given the younger generation today and their expectations, I don't think that's going to change. It's just going to continue to grow. I think we as a society have a lot more expectation. We're doing a lot with technology to really push the envelope on that. I think that's going to really continue. I think people are actually going to expect to be in a position where they can do a lot more diagnosing and treating themselves. And it will be, I will buy this when I need that. And I will do everything up until that point in time. So, that's kind of what I think may be out there for us. Not that my crystal ball isn't good, but.
Until last week, I saw people look up Theranos because I kind of felt that they were going to transform everything just because disintermediate doctors, or Dr. Watson and Dr. Google would take over for a lot of things.
I think there has been an evolution in the quality metric arena that there were very few metrics. We weren't being pushed by the insurers. Now we have too many metrics. Many insurers have different metrics. I think we're going to see a consolidation around what the right metrics are, the right mix of process and outcome. And I think that I think the fee for service will still be there, but it won't be the dominant form. And it will shift, so it'll be 80-20. And I hope by the time we get there that the incentives will be aligned appropriately. And I think that beyond that, the bigger arm of this is that the collaboration between the different continuums of care, parts of the continuums of care, will improve because we're so interdependent in terms of the metrics.
So
What about consumerism?
So one thing I would add, sorry, not about consumerism, but in general, is that the shift in the quality metrics, the consumerism, all of this will actually push us away from being a disparate system where food is independently owned, the hospital separately owned, a SNF facility separately owned, a rehab facility separately owned, and it's going to push with the hospitals to be the key players who will consolidate and buy up a lot of the practices, and the SNFs, so it will become more of an integrated system where they'll be forced to be either owned by one or work as one more than they are right now, instead of using their independent incentives right now.
But don't you think right now with all of the things that are happening, and none of them are black and white in terms of payment or quality or anything else, but I think it seems to me there's been an awareness created and a much greater involvement in people to really think about what it is that we're doing in terms of providing care. What are we doing in terms of prevention? How do we really have the right people working on the right problems? And I tend to think that that's going to have a way of leveling out so that we will start to package off certain care to people, that kind of work at the top of your license idea, only across the entire spectrum. And I think that with all of the factors that are happening right now, I think it's making us think a lot more about what we're doing instead of, well, I need to do this because these are all the things that are on the checkbox. It's more about, we have data, albeit sometimes too much, but we have data that's informing us of what works and what doesn't work.
I would argue that that's not true.
The data part?
The data part. The data part. The consumerism. The issue of consumerism is is there sufficient data for the consumer to make the right decision? I think the consumer is going to push us to try to answer the questions of what is right and what is wrong. But this concept of evidence-based data, the amount of real evidence to drive clinical decisions of what's right or wrong is just not there. So I'll give you a perfect example. I got an email this morning about a woman who wanted her gallbladder out because she has a 7-millimeter polyp in her gallbladder. And this is consumerism. She wanted an elective gallbladder. She went to her primary care doctor. I want my gallbladder out. There's no data to support that. Yes or no. It's gray. So the question is, as you start to have people practice at the top of their license, who's going to answer that question for that person? They're going to end up, and this is what will happen, the person will end up first with my physician's assistant, because now I'm trying to let them practice at the top of their license. And they won't be able to answer the question because I can't answer the question. That question requires a very complex discussion with a patient. And at the end of that discussion, it's still going to come down to the same conversation my father would have had with his patients in the 1950s, and my grandfather would have had with his patients in the 1920s, is we don't have enough information. I'll do whatever you want. That's what it comes down to. But I think that consumerism will push us, because people are going to have to pay more out of pocket. They're going to push us and say, do I really need that test? And we're going to have to honestly say, and that happens now, maybe you don't really need that test just because we've been getting that test for decades. Well, no, maybe we can get away without getting the test. So I think that there is the value of consumerism to force us to look for the answers to the questions, but the answers are not there now. Even with all this extra data, because we're not smart enough to know how to use that data.
Well, I mean, I think you're right. The definitive data is not there, but we are certainly moving much more rapidly into the world of data, and I think we are making strides towards being able to distill that data and actually, factor that back in with what we see. And I'm not going to speak for you, but as a nurse, I think, we can be driven by a lot of data points, but, at the end of the day, you still need to pay attention. You still need to look and see what's in front of you, the patient. And I think sometimes, and this really sounds cliche, but common sense is not really very common anymore. And that really can guide us to do a lot of things. So I think we have to keep that and help us to navigate through these waters of all this big data and all the things we can do. We can push the envelope. We do that every day now, and let's keep pushing it so that we can get more information that will help us.
And I completely agree with you, but as you said, was all the doctor really wants to know is, what do I need to do now? They don't have the time to run the data report. So unless the data report has already been run that says, I have a 37-year-old woman with a 7-millimeter gallbladder polyp, what should I do? And it pops up on my screen, that data is not going to be real helpful for me.
And see, I guess I go back to the comment about, working at top of license. Even though we may all be working at the top of our license, I still think that we need to work very collaboratively. And so by taking the people who are coming in telling me they have a sore throat, taking your time, and maybe taking my time with that, I think that we can start to carve up the day and use it more wisely.
But the consumerism would be the same comment I heard on the elevator 2 days ago was, I haven't seen my doctor in 3 years. I have not seen my primary care doctor in 3 years. So there needs to be a shift in expectations of the consumer that this is a team that's going to be taking care of it. I don't think we're there yet in some places.
Let's move on to, we have other questions. This gentleman right here.
How you doing? Andrew Berkman, PwC. So understanding the shift to value-based payments, if you were a provider designing a payer's quality incentive program, what things would you prioritize and how would you go about that? I know, Junaid, you mentioned simplicity and not overwhelming the providers, which I find really interesting as we're helping a client do something for the Medicaid-specific population, but really interested in all your perspectives.
I think I would push for more outcome measures. I think that's what a physician really cares about at the end of the day. How many of these patients had a positive impact because of payment? You know, the focus on some of these process measures, especially from quality perspective, is very limited. The benefits are always challenged by the new clinical guidelines and the perspective that changes over time. So I would push for more outcomes-related measures to see how what they did actually brought a benefit to the patient, not just what they did.
I have two teenage daughters, and you may all be underestimating the impact of self-diagnosis. You will be shocked if you don't have them already. Teenage children, they grew up with the search engine, and they will go to the search engine before they'll go to their parents.
The easiest way to increase anxiety is to Google your symptoms.
So my question is, it seems like the quality initiative is very transformational in healthcare, but it's a long, long journey. It seems like the economics in this country are going to beat us to the pain. And to me, it feels like at some point, we're either going to have to ration care or ration doctor pay before we can take the inefficiency out of the system through quality measures. So I would love to maybe hear from all of you on sort of who's going to win that battle. Are we going to look more like Canada in 20 years, where we're rationing care? Or are we going to look like we look today, but we're going to have doctors pay less?
I think the winner is the healthcare IT companies that are pushing all these data and apps and driving patients to go crazy worrying about what's going on.
But nine out of 10 go out of business, right?
Yeah, but there are always new ones popping up. And they use this data supposedly, which is very secretive. They don't tell you what their algorithms are, what their logic is, but it's supposed to improve your care and save your lives. So I think at the end of the day, healthcare IT companies will win the most.
As a healthcare IT company. Well, so first of all, I mean, you can't separate quality and cost, right? If I want to be really cynical, nobody cares about quality, right, with the government, right? It's all about saving our national health. And I think the problem is people have probably spent too much time on quality instead of saying, okay, I think it's, was it 25, 30% spent the last year ago. Promise you can't predict when that year is starting. And there's Medicare is starting to get better, but we just got better on living wills and end-of-life planning. Huge savings there, right? Another 30 to 40% is spent on chronic disease, right? Which is where unfortunately, I don't see the quality measures enough. I mean, there's a lot of diabetic measures, there's some good hypertension ones, but a little more focus on those could have a dramatic impact. And then the rest of care isn't a problem, right? That's your teenagers, that's pregnant women, it's really, it's not from, and there's a lot of quality measures focused on that, maybe not for the wrong reasons, but I'm optimistic we won't move to rationing care because we'll actually figure out how to solve things. And then we've got some huge headwinds against that, which is an aging population with dementia and an obesity epidemic, which is going to grow diabetes. So my crystal ball isn't very good on which is going to overtake.
Well, it's perhaps the only Canadian on this panel. Let me just address the rationing care. I mean, I was born and raised in the Canadian system, and that's where I got my clinical credentials. So, and worked for quite a while. And I think, I hear it a lot on this side of the border about rationing care. And frankly, I don't remember ever standing in line for loaf of bread or health care. But there is some perception of that. The one thing I will say is that I think all of us need to be able to have conversations about the kind of care that should be delivered to patients. And I think there are, well, I don't think, I know, because I've had them, hard conversations about how far we go with some of this stuff. How far do we go with end-of-life care? And personally, I have been cynical enough to sometimes stand in the room and realize that somebody was taking the easy way out because they couldn't look the family in the eye and say, I know it's your mother, and I know you love her dearly, and you wish she would be here forever. I can tell you beyond a shadow of a doubt, she will not be here forever. And you are doing her no favors at this point in time by asking me to do all of these things, because she, if she could speak, would not ask you for that. So I think we've got to get a whole lot better about having those hard conversations, and it's even more difficult here than it was in Canada because of the litigious nature of our society. I mean, everybody's like, I can't do that, I can't say that, because the next thing I'll be sued. And I'm not saying that to be critical of the American system, I'm saying that's a fact, and we've got to figure out ways to work around that. So, you know.
I agree with you. I think that I'm an intensivist, so I've spent the last 25, 30 years in intensive care situations, and I've seen a change in the way families come in and approach things. And I think that if there's a consumerism involved in this, it's, yeah, I want all this stuff, but then at some point they say, no, this isn't what mom wants, and the quality of life is just not going to be there. I want you to back off. And with that conversation change from the patients and their families, there has been a change in the providers, and the providers are far more willing to say, okay, we'll let nature take its course. So I think that's where the waste, you know,
Your last 5 years of life.
The last 5 years of life, that if we could start to rationalize use of resources in that period of time, then there won't be any rationing, there won't be any cut and pay for anybody. Our biggest challenge is not our physicians, it's our nurses, paying them enough to do what they need to do.
It sounds like a good example of the impact of the growing impact of consumerism on healthcare. In this case, a very beneficial impact. Questions here, and then.
This is for Mr. Grossman specifically. We have 3 people very involved in the clinic side, and then from the technology. So, were there customers coming to you saying we have payers who want these quality metrics and we don't know how to get them, or are you pitching there? Where is Athena?
So, I mean, Athena's model has always been to try and be ahead of our providers, and stay ahead of regulation. So we implemented, you know, all of the many HEDIS measures years ago, and then, you know, as Blue Cross came out with their HLSC program, we had it instrumented. So on behalf of, we sort of, you know, we have a guarantee now that doctors won't be penalized for PQRS if they're on Athena. So while we're not always fans of government regulation, we want to help our providers stay ahead of it. So that's been our incentive for doing it.
Okay.
I was just, this is for any one of you want to answer. I wanted to know your guys' opinion on minute clinics. It seems like those are gearing towards consumerism, but that also helps with, you guys were saying, the top people working at the top of their pay or degree or whatever it is. And maybe with the increase of minute clinics, that does increase consumerism, but it could increase the number of sick patients who are getting to the actual hospitals. So opinions on that.
So I'll start off with that. So as an IPA, that became a huge problem for us, because these minute clinics were not only driving consumerism, they were taking our patients away, they were driving to unnecessary care, unnecessary pharmacy costs, and it actually pushed us to change. So as an IPA, we actually developed a walk-in center within the hospital to divert patients and give them an option to go there instead of going to these mini clinics for the ER. So the benefit was that it reduced our overall ER admissions and also pushed patients away from these mini clinics by providing them an option. So it did push us to change, which was a positive thing.
So I've got a lot. So we have Target, Minute Clinic, and others clients, and we have 10,000 primary care doctors. So we did some data analysis, and it's all in a blog somewhat from 2 years ago. But a couple of interesting things. One, which got me a lot of grief from doctors. One is clearly these people have figured out a much better operating model. Right. And it's a little bit like what Ido said earlier, like they're the king of the Z-Pack, right? Because they're cream skimming. It's the 80-20 rule. They're dealing with sort of 80% of the non-problem patients, right? And giving out Z-Packs. And they're really good at it.
It's run like a business, to be honest with you. So they have a different.
Is that so wrong?
No, it's not. It's not. It's not.
This is the next room if you want me to get it.
The other thing that was fascinating that got me in a lot of trouble is we looked at improper prescribing of antibiotics, which is a quality measure. So someone comes in with a diagnosis of bronchitis and no other complication, and you give them a Z-Pack, which is completely not indicated. And what we found is Target did it 3% of the time. One of the reasons was, and it turns out when you work people to the top of their license, they're better, or you put it at saying no. Whereas, and then you talk to the doctors like, look, I would be out of business in Lexington, Mass. if I didn't give the mother the antibiotic. She's going to go to another pediatrician, right? And so there is this, so I mean, I feel for both sides, they're both my clients, but it is interesting, you can actually have better quality on a narrower band of issues in a larger organization sometimes, like a Minute Clinic. So I think they do a good job. The challenge is how to make the rest of the healthcare spectrum viable. And you know what my other clients have done, sounds like what MACIPA's done, is you stay open until 10 o'clock. The people aren't going to Minute Clinic necessarily because of the free parking, or like, or already in CVS, right? They're going there because they know it's going to be convenient. And there's nothing that would prevent larger medical groups, it's harder than one or two doc practice, from figuring out how to be as convenient, and then having the doctor on staff that can see you immediately if it is more emergent.
And I would just add a couple of things. One is the 1 or 2 docs now actually are working together to have them from one place for them to where they can share hours. And the other thing is, for a while now, these mini clinics, it didn't matter, they didn't have any of their own quality metrics to look up to, or their financial incentives. Their incentive was to make the patient happy so they return. So they definitely did that. But I think now Blue Cross Blue Shield and some of these payers are moving towards having specific quality metrics for these mini clinics, which should help the system overall.
And they're always going to win it, though, just to warn you.
CVS says very clearly, if you listen to anybody from CVS or Med Clinic, this is the future of CVS. This is the why people will go into that store and how they'll prescribe other drugs. I mean, that's fundamental to their business model.
And props, that's why they stopped selling cigarettes.
Yeah.
There was a huge issue. I mean, they're transforming their business.
Okay, question right here.
So I'll just add, as a mom who's taken advantage of Minute Clinic over the years, the dirty secret is Minute Clinic is not a minute. They lure you in and then you sign in. I've learned it's like an hour, 2-hour wait. But
But you get a buzzer, right? You go shop and
that's the next step, like a TGI Fridays or something. I think you could take off. When you have a kid with a fever. But my question was, is patient satisfaction is one of the aspects of quality. And what I don't understand is that you're charged as either a provider or a payer with being responsible for the objective aspect of that. Really, patient satisfaction in the eyes of the patient is subjective. And I know we're in the early stages. What is the plan going forward as time goes on? How do you harness that? I mean, what I hear from folks is that response rates from surveys post-discharge is, I don't know, 20, 30%. I mean, way less. So,
30% would be great.
Patient satisfaction, and that turns into like your reimbursement. I don't get that.
I don't have a solution, but I also want to iterate my frustration with that. One of the problems is we do have this patient experience with all our contracts, Blue Cross, CMS, all these payers. And the worst thing is they get these surveys a year later. So they had the visit in 2014. Sometime around the summer of 2015, they'll be asked about a visit they had a year ago. And if they recently had a visit which wasn't good, they're going to put a negative comment on that. And it's going to kill your quality scores because patient experience is a huge part of it. So I just want to say that.
So one of the things that's really interesting to me about these satisfaction surveys is, one, the timeliness in which they're given, and then the questions that are asked. And I was having this conversation with a potential client the other day, and they were really struggling with this business of their scores. The response rate is terrible. The numbers are terrible. And we were talking about, the whole point of asking those questions should be to help you as a business, as a clinical provider, determine where you're falling short of the mark. what are the things that you need to focus on? It's another data point. It's not the only data point, but it's another data point that can help you to understand what it's like to be in the other shoes on the other side of the table.
I'm going to be the cynical one here, right? I mean, they solve this in the auto industry, right? The person just says, you're going to get a survey, and if you give me less than a 5, I get fired. So please give me a 5. And if anyone's ever bought a car, that's what happens. And doctors, unfortunately, are going to have to do that. The other fascinating thing, if you look at the data, the people that really hate it are the New York health systems, because in the South, people give higher satisfaction ratings, even though they're not as satisfied. And in New York, people give New York are weak. Nothing's perfect. Right? And so there are these really interesting things, but it's...
And these questions are not simple. There are a couple of 2-3-line sentences, and half the time you're confused as someone who's trying to look and improve on these. How does a patient feel who's 65, 85 plus answering these questions? So.
One promising solution has its problems, but it's promising that the VA is using is survey kiosks that are located in the clinical site, and patients can fill them out as they exit the system. Of course, there's also the potential that they would be subject to the bias of the clinician who say, just give me the 5, like Em was saying, but it does have a promise of increasing the response rates and also of giving feedback in a much more quickly.
If I can interject, this is an area, this is actually my specialty of work. My name is Gloria Platel, I work with GSP Squared. So one of the issues that comes up is that surveys, because of their slow return time and their low responses, and because the survey questions only hit on certain questions, and there's no opportunity to dive in. So then there's another set of mechanisms that come into place. One of them is called Patient and Family Advisory Councils, which every hospital in Massachusetts now is required to have, and some independent practices are now starting to have them as well. And that is a group of patients and family members of patients of that practice or that hospital who then are able to really dive deep and discuss an issue. So you actually can come up with what real root causes are and what possible solutions are. So that's one way to actually work on improving patient satisfaction. I've seen that work actually very, very well.
I mean,
and then the other, I just want to add, the other thing is that I work with patients and family members regularly in these efforts. They really complain about these homegrown surveys of different practices where the administrator or the physician are standing next to them. They really don't like it. So there's a lot of patient and family pushback from those independent initiatives.
So the patient advocate group that MACIPA actually does have as part of the ACO requirements. And there has been some benefits to that, but the problem also is that the people engaged in that are necessarily more in a positive engagement with the APA. So it's hard to get those people that are really unhappy to come and talk to us and discuss what their issues and concerns are.
So what we do systematically is, although we pay too much attention to the numbers, we take all of the comments that are written, and there are hundreds of comments that are written, and every comment is distributed to the line person that's responsible for that area, and a follow-up telephone call is made to that person, and then there's a report out at our leadership group that we spoke to Mrs. Jones, she complained about this, this, and this, I think that the complaint is valid and we need to deal with it. So that's it. It takes a lot of time to do, but those subjective comments, the objective scores and the subjective comments, there's tremendous richness in those subjective comments.
And again, this is satisfaction is getting at an outcome measure by surveying, whereas I think the growth of consumerism is going to get at it by the number of people that switch doctors unless they're forced into a narrow network. And it is fascinating to me because we've looked at physician retention. Only 30% of people don't return to a doctor for a second visit, which was a much lower number than I would have thought of. And either that's because they're afraid to switch doctors, and I know their satisfaction isn't that high. And the number of people that actually fire their doctors is low. One of my good friends just fired her doctor. Yeah, I gave the whole story at some point, but it was an event, and we actually fired a pediatrician 2 years ago and switched. And it took a while, right? It's not easy. These are really learned people who, even if you don't like them, appreciate what they've got. And hopefully satisfaction surveys can help those doctors that are not satisfying their patients realize where they may be wrong. But there's also a lot of other data people can look at as proxies for patient satisfaction. In terms of repeat visits.
And the question is, why is satisfaction important? And I think the data says that if your patient's more satisfied, they're more likely to take their medications, they're more likely to follow through with the recommendations of the provider, and then we have to assume that their health will be better. So there's some reason to look at it beyond just my patient's not satisfied or satisfied.
Okay, we have time for a couple more questions, right here.
Is there any data on patient experience in a value-based reimbursement system versus the traditional fee-for-service reimbursement?
I mean, we do surveys for value-based model, but I don't think we've done a comparison with the fee-for-service patients. Sorry.
Patient experience or patient satisfaction?
Choose. And whatever there's data on, tell me about it.
Well, so I'm trying to figure out what patient experience would, how I measure it. Right? So
Well, the AQC, the Blue Cross Blue Shield AQC, a huge part of the weighting goes to patient experience through the either MHQP or the various different surveys that they use. They've done studies that show the quality generally has improved for the provider groups under the AQC contract versus those that are not, but they might have gone deeper and tried to see then what weighting patient experience has had on that, but it's inherent in that, but I'm not sure specifically.
So prior to coming to business school, I worked in decision support, and I always felt like one of the struggles was giving people the data they wanted in a timely manner. So I'm kind of curious, what methods you're using to give people the information they want quickly and kind of correctly.
So I can tell you what not to do, which is Medicare just announced that the PQRS benchmarks for 2014. So in the 2013 benchmarks came out in September of 2014, right? And so we've been basing our 2015 results on those 2014 benchmarks because we were going to get the 2013, we're going to get the 2014 numbers in September of 2015, right? So you submit your 2014 data in February. I don't know why in this data computer takes them 7 months to crunch it, and we then get them in September. They've now announced we're not going to have until January of next year. So it's basically all of our doctors are running a race without knowing where the finish line is, and then at the end of the year they'll be told if they crossed it or not.
Is that what you're really asking?
No, so I'm answering that. So what we've believed all along is it's got to be at the point of care. And so right in the Athena electronic health record, we have something called the quality tab, which based on the patient's payer highlights all the known gaps in care, and you can click to refer them for a mammogram or anything else. So that's what we try to do. It doesn't get at the other problem of the patients that aren't in the room, and you're talking about how you look at those. But
and it seems like there's so many fields you can look at. How do you make sure you're giving them all the information they can get and all the information they want? But
the quality tab is very specific. So it lists for that patient what is missing.
So that's the EHR data. I mean, I think there's a lot of other data that we have in healthcare that we can actually use to inform the work, the care that we need to provide. And I think, one of the things that's really important is as you have conversations with your care providers and your executive teams, it's about finding out the information that they can actually do something with to make a difference. I mean, we could bury ourselves in data and reports and not be one bit smarter than we are right now. But if we really look at what is the data that we need to inform us to be able to make a difference, move the needle, then we really need to look at where can we collect that data and set the expectations of where it comes from, how long it takes to get, and really set up kind of our cadence around that. I think that's what I've seen most effective when I work with clients, to really manage the expectations, and to really have them take that data and embed that in the care and the management of their particular operations, be the clinic.
And there's some limitations you just can't get over. A lot of the process measures are based on claims data. You gotta wait 2 months for claims data to come through. So your patient could be getting the treatment somewhere else. You wouldn't know right away because they're not in your system. It's a separate communication issue. So there's some limitations that will be there regardless.
Well, this has been a very, very interesting and lively discussion. I want to, first of all, thank our panelists. And I'd also like to thank one of our students who's organized this session, Kim Gomes. And thank you for such a good turnout. It really, I think, is very auspicious for quality improvement to see that there are so many people who are interested. So thank you as well.